What's up, Matt? How are you? How do you feel?
Hey Dave, how you doing?
What's up, Henry?
How are you doing?
We're good. I feel like the last time I saw you was when we were in Atlantic City. I don't think I've seen you since.
Yeah, no, that was the last time at Sono Games.
Maybe if we tease Adam enough, he'll have another one.
Yeah, well, we'll pressure him enough, I think. Are your volumes on there increasing? Because we're seeing a surge in our hospital right now.
I think it's been kind of steady. I don't know what it is comparatively to year to date before pre-COVID. I know we're up. We were up pre-summer, and our summer numbers were also pretty high. Our acuity was high, Henry, and then we're still seeing COVID. We're still seeing a ton of COVID. But it's really those respiratory kids. We've had a lot of rhinoentero kids that are awful, which I don't. It's not sure why, but it could just be your normal. Hey, these kids are normal kids who are getting really sick from just everyday viral stuff. But I just we're still seeing a ton of RSV, and yes, Matt, make sure you wear a mask in that small place.
So we'll get started like around in a minute or so, give more people time to log in, and then
It's okay. It's a holiday today too.
oh yes, Matt mentioned that the other day too, I think.
What holiday is it?
It's the Will Mac holiday. No, I'm just kidding. It's Yom Kippur.
Oh, right.
All right, so all right, so good afternoon, everyone who's joined us today. Thank you. Today we have Dave Teng from Cohen's Children's in New York, who we're presenting today. Dave, once again, thank you for presenting.
Oh, all right. And make sure that this is working. Let me press play. All right, Henry, you see my screen?
Yep.
All right, cool. Happy holidays, everyone who is celebrating today. Hope everyone has an easy fast. I want to congratulate Henry on his promotion to associate professor. Henry, Henry, you've really done a lot of work with PEPEC, and it's been awesome just to watch, especially during COVID. And we haven't had an in-person kind of thing for a while, so this has kind of kept us going and kept all the conversations going. So really, hats off to you, and really congratulations on your promotion. I think it's awesome. All right, so today I have the honor of kind of a few objectives. We're going to describe the use of POCUS in kind of various ENT pathology, such as PTA, RPA, and some foreign ingestion. I feel like there's a couple of really neat images I wanted to kind of go through, and I'll make sure we kind of have time to discuss the utility and the use of fast exams in pediatric trauma. It's been kind of coming up a little bit in our shop, and just to kind of see what take the temperature of the landscape of everyone on the call, and what you guys do at your shop and how that kind of plays out. And we'd like to see how you guys succeed, navigate, or manage when it comes to those things. So, okay, so let's start. Case 1. Okay. Let's see if this thing moves. Okay, good. 14-month-old baby girl with no past medical history presents to the ED with daily fevers for 13 days. The parents also state the child has had a cough with nasal congestion during this time. Over the last 2 days, she hasn't been eating, and they're concerned for left-sided neck swelling that is warm to touch. She's being sent in for evaluation for KD, and Henry, I'm not sure, and everyone who's on the call, who you guys are seeing, but we're seeing a ton of extended fevers. Surprisingly, not so much MISC, but really just from everything from adeno, rhinoentero, RSV, even the regular coronavirus that's not COVID. Even we've had a slew of human metapneumo. So everything's out there. But this kid had 13 days of fever. So on physical exam, you have a 3x3 tender, warm swelling to the neck, and a white count that came back because the nurses were fantastic. And you got a white count of 18. Okay, so what are people's thoughts? I know my fellows are in the office, so what are you guys thinking? Josh, Lindsay? I didn't hear you guys. I don't know if your microphone's on. Got it. All right. Thank you, Josh. All right. So you get an lateral X-ray of the neck. Okay. We always try to look at the prevertebral space. And this kid's prevertebral space is pretty thick. On the average, a kid less than 6, anything above C4 should be at least half the size, if not the same size as below. In this case, it's pretty thick. As they get older, it's probably about half the size of between C1 through C4 and C4 through C8. But the idea is that this kid is pretty thick. Ended up getting a CT. If you looked on the CT, you're also kind of seeing the outline of a collection. This is on the left side, which kind of accounts for the swelling that you're seeing on the left side. But the idea is that we're kind of seeing a whole bunch of inflammation, and really just not able to kind of see the entire extent that we would otherwise. So here's a collection here that's prevertebral. All right. So Dr. Malia with Dr. Sivitz and Dr. Kaiza, when you guys did this, it was a novel approach, and it was actually kind of neat because you're able to then kind of assess what we normally would get at CT for, and part of it would be, using the linear probe, and, under the angle of the mandible, you have the probe marker facing the patient's ipsilateral ear, and the probe should be kind of 90 degrees to the neck. And it gives you a nice look using the vertebral body as a floor, to kind of see what's going on, any collection, any inflammation, any thickness. You do have the pharynx and the vessels as kind of your base. So we started with the lateral neck just to kind of see if we can actually appreciate the extent of the RPA. But the idea is that, so on the left, using the linear probe, we did try to capture the the vertebra here, and you can see the vertebra here. You can see the carotid as it's pulsating on here, and some lymph nodes that are collecting here. So you're also seeing this left neck swelling. Is it an abscess or is it just a matted bunch of lymph nodes? In this kid, this was not only a collection but also lymphadenopathy that extended further. But here you actually see the vertebra and vertebra here as you then see this collection on both sides. So let's just kind of go through what is it that we're actually looking at. So this is kind of a schematic on the neck, as the patient is lying supine, if they're able to. Some of the smaller kids, I actually just put them on, you can definitely just lie them down with the parents, which I think was also reported by Laurie and Henry's team as well. But the idea is that, what is it that we can actually see, right? So is it that we can, so here's your linear probe as it kind of goes over, okay? But the idea is that sometimes we kind of need a little bit more. I apologize for the keynote. It's not acting right. So anyway, so if you kind of look at it with, right, if you look at it with a curvilinear, it's going to give you kind of a different view to it. So I'm going to kind of show you with the linear probe. So with the linear probe with the vertebra in the back and the collection here with the matted lymph nodes, once you actually change it to the curvilinear, it gives you a whole different look. Sometimes, for me, yes, you could definitely see the collection using the linear probe, but the curvilinear also gives you kind of that wide angle lens. It's probably the depth is really no different. If you look at the depth markers, 1, 2, 3, 4, 5, maybe 6 centimeters, there's probably no difference since you have the vertebral wall, but it's just a wide angle lens. For those who have Zenaris in the audience, it's you guys, if you can get the C9-3 probe, it's really fantastic. It's more of a higher frequency curvilinear, and it really gives fantastic pictures. We use it for lung as well as other entities. But again, this is a superficial, but it also gives you just a whole look. So again, you have the vertebra here, as well as the collection that's here that you also appreciate on a linear probe. So next time you actually have a positive CT finding, or if you want to take a look, use your curvilinear just to kind of give you a better wide angle look. Okay. Going. I apologize. This is probably my internet, just as long as it doesn't crash. All right. Any questions while I'm waiting for this to kind of go through? Any questions for stuff to go through so far? All right. I know Will Mack is making fun of me now that he's like, see, I told you should use PowerPoint. And I'm just gonna come out. Yeah, it's probably could be. Are you guys hearing me okay?
Yeah, we're hearing you fine.
Good.
All right. I'm gonna just stop sharing and seeing what's going on with my keynote. Sorry about that, guys. This is a lecturer's worst nightmare where it just freezes, but we'll be okay. Henry, what are you guys seeing on the screen?
Just you right now.
Okay. Internally freaking out because just can't get my keynote to. All right, Henry, I apologize. I may have to just log off to see what's going on.
Okay.
I apologize, buddy. Give me a second.
Yep. While Dave is getting back, just for my own curiosity, I wanted to know if anyone else is sort of tempted to try to see recognize an RPA using that transcutaneous approach. I don't know if anyone else has been doing that regularly or has attempted.
Yeah, I usually take a peek. I'm still not a place where I'll completely rely on it, but good clinical suspicion as I'm examining the kid, I'll bring the machine in and just take a quick look. It just expedites how quickly I need to be worried or get the kid to scanner or call ENT or all the above as well. But I've caught a few, and then a few where I'm like, oh, maybe not, where it'll show a little collection on the CT.
Okay.
All right. I think I'm back. Henry, do you hear me?
Yep.
All right. Sorry about that, guys. Stop smirking, Mac. All right. Okay. Henry, what are you saying?
I'm seeing the your whole screen, not the whole the power, the presentation. I'm seeing with the slides on the side.
Okay. Do you see my slides yet or no?
No, not yet. I mean, I'm seeing the whole screen that you normally see with a Keynote.
Okay, that's weird. All right, let me share this again. All right. How about now, Henry?
Let me see. Yep, no, I'm seeing the slides starting to come up.
All right, cool. All right, sorry about that. So if we're looking back, so going back to our case where we're looking at the linear probe versus the curvilinear. So on your right, you have the linear where you have the esophagus here, and then you have this entire area here. This could also be probably the hypopharynx, this probably the start of the trachea, but you have this entire area that's just hypoechoic and complex. You're not really sure what this is, but if you actually bring it to a curvilinear, it gives you a little bit better perspective. And this is now probably airway, or at least the hypopharynx in the beginning of it. And you see this large hypoechoic density that ends up being the same collection that you guys see at the bottom here. All right. All right, and here's the CT that's kind of showing us how this is looking. And part of it is just allowing us to kind of see how this is not going to transition. Henry, I really apologize for this.
No worries.
Man, this sucks. I apologize. I'm gonna probably do it without playing and just kind of play it off the slides and see if that helps.
Yeah.
Dave, I feel like people have had benefit turning off their camera as well to sort of save bandwidth before when they've been having internet troubles.
Yeah, I like that.
Not that I don't want to see.
I appreciate that, man. Yeah, I'm literally frozen. Okay. All right.
Hey, Henry, kind of follow up to your question about the trying to actually do this in practice. I'm curious how many people besides just the point of care side have a radiology department that will do this.
Personally, like for me, what I done, what I seen, not for RPA, but I've seen some techs that are comfortable looking for a peritonsillar abscess going the transcutaneous way. I haven't seen any radiologists attempt to do that for to detection for the RPA.
At our shop, the radiologist won't do it for either RPA or peritonsillar. I've tried to get them to do it for peritonsillar, and they won't do it. They just tell me put in the CT rec.
It's funny, but we're pretty similar. I've had a tough time getting radiology for both PTA and RPA, and we've had some conversations about it. Even when I had one case where I sort of saw a bit of a fluid collection for a PTA and walked back and spoke to the technician specifically about it. The image that was done of the neck and soft tissues was more superficial. So, you know, it's kind of, I'd love it to have more support from radiology so that we could have a bit more of a collaborative approach to doing this more often and mitigating CAT scan use in these kids.
Henry, do you see me now or no?
I see the whole keynote thing again with the the slides on the side,
Right,
but
so
I think if it works that way, it should be okay.
Yeah, I think we'll just do this, and I apologize for everyone's from a technical standpoint, but we'll do it old school. All right. So for the most part, we were talking about linear versus curvilinear. You can see this hypoechoic area, and then the idea is that that's where we're looking. I hate that you guys don't have the animations, but we'll make do. All right. So here's that collection here. You know, when you put this kid supine, here's the anatomy, and just kind of making sure we're all on the same page of what we're looking for. And here is the vertebra, and then here is also where the collection is. Henry, do you guys see my arrow?
With the yellow arrow or your
My mouse arrow.
Yep, I'm seeing it.
All right, great. All right. We're definitely old schooling it here. All right, so here's the perspective, vertebra collection of fluid there. All right, and this is the second one. Let me see if I can play it for you. So here you can actually see it where this is old. This is all the collection with the landmarks of the vertebra here. Okay, so these are really true RPAs, and especially in this kid who had symptoms and also had swelling of that left side of the neck. But if you can see here, we're really putting the probe really on the sagittal look, and you can actually really get a good perspective of kind of how this is. All right, so we'll take that's case one. The other thing I wanted to point out is one of the neat things I love, and it'll play into some of the cases we'll have coming up, is that you can actually see the esophagus. So here, if you have the vertebral body, that esophagus really just sits right on top of the vertebral body. Here you can see some of the vessels. And here, this is kind of where this is correlating to. I'll play later, but you can actually see peristalsis. You can also see just, we'll talk about food impaction later, but this is a pretty easy image to get. Case 2, 8-month-old with no past medical history with 1 week of fever and has been given antibiotics for otitis media on the onset, but continued with fever. Parents deny URI symptoms and no sick contacts. Currently breathing with mouth open and cries and sounds different. Parents report difficulty eating and drooling more than normal. They also note swelling under the left ear. So when you're looking at it, and the one thing I thought was impressive at the chart, they basically said on Saturday, she started to turn her whole body to look around. She woke up and had one episode of emesis, and the parents were concerned that she was sticking her tongue out more. So for an 8-month-old, this is pretty impressive. So when you're looking on here, this is also where if I'm taking away this area, this prevertebral space is incredibly thick. and especially in the, almost on the hyperflex area, but neck. But the idea is that that thickness is pretty impressive. She also had a high white count, 27, but the idea was just to kind of see. So here's a CAT scan, where the CAT scan is showing that really that collection in that prevertebral space. Here's the sagittal look. That sagittal look is also that collection. We're going to kind of see what that really looks like on ultrasound. So here we're taking an axial plane. Here's the trachea. It's not really the true tracheal rings, but this is probably the hypopharynx larynx area, just to give you guys kind of landmark perspective as we're doing anterior, posterior. This is left and right. We see a collection here, this hyperechoic densities here are the vertebra. And you see this really like hypoechoic complex fluid collection that kind of moves, right? You almost get a swish sign. So that's all abscess for this kid. And you can actually appreciate that on the axial CT as that collection kind of goes all the way. All right. And as we're here, we're also kind of taking another look. This is just another look at an axial, and you're really getting a true sense of how extensive this goes from superior to inferior as we're coming into the thyroid tracheal rings. All right, and here's just a little bit more of it. It's just pretty impressive, and I was just amazed when, and obviously this kid wasn't moving too much, but when this kid came in, you're like, there's gotta be, is this meningitis? Is there something else going on because of the fever and not moving the neck? But with the neck swelling, that's usually not meningitis, and not being able to eat and, sticking the tongue out, again, that's usually not meningitis either. So at least we didn't have to tap the kid, but the kid did go to the operating room. And here's just a few more images, just so this way you can kind of get a sense of how this looks. All right, so if the kid is now supine, and you're looking at this collection with the vertebra here, just this way your eyes can kind of get a sense of the landmark. Here's your probably your tongue up here, and then you have your carotid and your vessels. So this whole hypopharynx area, and actually this is probably jawline, this is probably mandible that's kind of coming in, but that's kind of where you are if you're looking at landmarks. Okay. And then you go from here again. This is, didn't realize I actually had an arrow there, so which is good. So again, just, depending on what you have on your cart, if you don't have the C9, that's okay, but the idea is that gives you different views. Even if you have the linear probe is going to give you still a look and still something that's there. I've actually talked to our techs in trying to do this, and their whole head and neck, they're very thyroid savvy, because that's that comprehensive test that they do. When you start looking at retropharyngeal, Antonio, you were mentioning, it's almost like you have to come up with your own protocol for it. Okay. And then we're showing here, I just like showing these clips because it's just amazing the extent of which this pus was here, and they drained quite a bit. And here's the axial view, and this is the transverse view as well. Okay, so the idea is that, so how are we really doing this? So actually that shouldn't be there. Oh my goodness. Okay, so let's go through here. What happened to my cases? All right, sorry guys. All right, so we're gonna go to case 4. All right, so 7-month-old, no past medical history, presents with choking episode. Patient grabbed a piece of orange and put it in her mouth while parents were eating dinner. While trying to eat it, she choked and started to cough. Dad performed back thrusts, and the patient had a single emesis of milk. The father did a finger sweep and felt a piece of orange. The patient currently has no distress and no respiratory symptoms, and no drooling for Strider. Child is refusing to eat. All right, so one of the cool things I think, and Danny Paulin out in Akron really, we were looking at this when she was a fellow with us, but it was really cool. You can actually see peristalsis and as the kids are drinking. So this is a sagittal look using the linear probe, and you're looking at from top to bottom. You have your thyroid tissue, you have your hypopharynx over here, and then you have your food bolus as it's going through. But for the kid, so this was actually a very interesting case because the kid was actually asymptomatic, but yet wasn't able to drink. And dad still felt like he was feeling something when he did the finger sweep. So this is an axial look when you're looking at it, and you probably see some familiar structures as you have the thyroid, you have your trachea, and then you have your esophagus here, and then your esophagus, it's a little dilated, and you can really kind of get a sense that there is just something that's not supposed to be there. And as we kind of travel through, okay, you're starting to see this hyperechoic food bolus here. You see some fluids, but with the linear probe, you're just not really capturing everything that you need. All right, so we switched to sagittal approach. Here's some of the neck muscles, lymphadenopathy. You have your vertebra on the bottom here, and then you're starting to see a little bit of the esophagus, not really as clear. So with this, just a suggestion to use the curvilinear. So this way, you're actually able to actually see different parts of it. When you actually can see where here's the vertebra as it correlates to here, and you have a food bolus here. And if this is head, this is neck, the idea is that shouldn't be there, and we already we looked at here where you're able to see the food bolus passing with nothing else in the residual. But here with this kid, you can see on top of the vertebra, there's still some hyperechoic foreign body or something that's still in the upper esophagus. So when you're taking a look, here, just if you remember from case one, here's the esophagus here, and here's just kind of gas. So you can really see the esophagus pretty well. And then we keep bring it back to this case here. Here's a normal esophagus, and here for this kid, this whole hyperechoic area just shouldn't be there. And this is where the food bolus is kind of stuck. And then as we go forward, you can kind of take a look even further. And these images really kind of give it a good credence and kind of where it is. And even as the timing goes through, we're actually seeing it kind of move. And this is now the esophagus is right above the cardiac, the kind of the arch of the aorta, kind of around T4, where all those things are, right? We talk about three areas where coins or food get stuck, right? It's the thoracic inlet, it's the angle of Louis, where you have the carina, the arch of the aorta, and the pulmonary vessels. So that's kind of where this is kind of getting stuck, and the last piece is down at the LES. Okay, but that's kind of giving you a sense of where that is. Again, this is an axial look all the way down. So here's the upper part of the vessels. Here's your thyroid, and you're just seeing that full food bolus right there. All right, and then here you're actually seeing it where that food bolus is kind of still getting stuck. All right. All right. So we stepped away. We're talking to ENT, GI, and trying to figure out what's going on. And we went back in a room, and the dad's feeding the kid Pedialyte. So as you can see here, so here's the vertebra, and here's the kid drinking. So the kid's actually drinking Pedialyte, and it seems to be passing, but there seems to still be this kind of food bolus that's kind of still stuck around here. So it's not fully done, but it's not fully obstructed either. And that's probably why the kid wasn't drooling, vomiting, or having any other signs of emesis or obstruction. And then here, you can actually almost see that, the kid's drinking, and all of a sudden you can kind of actually see that food bolus moving. And afterwards, and kind of seeing all of it kind of move through. And then here is kind of the last bit of it. So literally on camera, you can actually see everything kind of moving through, and now you're not really seeing any more of that hyperechoic area in this area anymore. So literally as we were filming the kid passed whatever it was, and then really from there on was able to tolerate milk and other things. So Dad kind of helped the management a little bit, even while we were trying to figure out who to take this. GI and ENT were kind of fighting who should be doing this, but in the end, so in the end, it looked like he was able to just pass it on their own, and you can see this just kind of going through, which is nice. All right, and then just last case before we get to fast, a 12-year-old developmental delay, history of eosinophilic esophagitis with multiple prior food impactions. Tonight she was eating a plum and was choking episode and coughing and gagging. So this kid, I actually saw this kid twice. And when she came in, Mom said, yeah, we did it again. She choked on a piece of plum. And here you can kind of see that using the linear probe in the sagittal plane, you can see this food bowl is kind of getting stuck. Not really great images, so we switched to the curvilinear. And you can actually see that food bowl is a little bit worse right here. Right? And here's a vertebral body as it is in that orientation here. All right, and then here's the axial view, and you can actually see as we're coming down from superior to inferior, the trachea, thyroid, and then you have this food bolus that's right here. There really shouldn't be. Okay. All right. And again, that's the food. When the kid ended up getting upper G, went to endoscopy to get it removed again, twice in really 2 months. So these are just ideas. I actually had a case of PTA. I'm sorry, it just didn't come through. But in the last bit of this session today, I do want to just kind of pick your guys' brain about fast. All right, just a typical case where you have a 12-year-old pedestrian struck, presents in the ED with EMS and known to have slight pain and bruising of the periumbilical area. Vital signs are stable and the patient is awake and alert. You bring them over to ultrasound, you perform it fast. So we know what's the literature that's out there, right? More recently, in February in 2001, they did this was published in PEC, a systematic review of what's really out there. And, in conclusion, they, hemodynamically stable kid presenting with blunt abdominal trauma, a positive POCUS and FAST exam results in likely, which we kind of make sense, right? If it's positive, it's positive, but a negative examination result alone cannot preclude further diagnostic workup, right? And I think we know that if it's negative, we just can't kind of rule out. And of course, the Holmes paper that came out in 2017, it just says that, when compared with FAST versus FAST and FAST, the use of CT just wasn't any different. So, part of a lot of the literature out there really just doesn't support it. But, from an education standpoint, our fellows have to learn it. There is a utility for that. And, the idea is that, what part of FAST will change your practice. I want you guys to start thinking, and we'll take kind of a survey in a little bit on, and want to get your thoughts on does FAST really change your practice? Do people even do FAST in their institution, right? So what is it that will actually get you further, right? Otherwise, in our case where, the kid got hit by a car, but his vital signs are stable, right? Is it a positive right upper quadrant that's going to get you there, right? Because the labs probably aren't back yet. If they're stable, in our shop, they're likely going to go to a CAT scan. Left upper quadrant. If it's positive, then what? What's going to happen? Again, in the stable kid, kid still is probably going to go to CAT scan, at least in our shop. We've had cases where they're hypotensive, we're treating and we're still kind of getting scans. So the thought is that if it's a pericardial effusion, that's probably a little different. I'd love to see what you guys think about it. But, if you have a pericardial effusion, that's going to change your management because, with a normal stable kid, that will probably be a game changer if you see that on a fast. Pelvic fluid, right? We've already known that in kids, pelvic fluid is probably more common than any other area, right? Pneumothorax, we know that if we have a pneumothorax, we can at least treat that. But in a stable kid, and not at tension yet, is that kid still going to get a CT, right? And a hemothorax, is that going to change at all, especially in a stable kid? So just, for me, I just want to just kind of throw the ball to the group. I'm going to actually change my share and do a quick poll just to kind of see where everyone is. And Henry, I really apologize for the presentation. I really wanted to be a little bit more animated and more thorough. So I apologize for that. I'm gonna see if this comes up here. Okay. All right. All right. All right, Henry, what are you seeing?
Yep, I'm seeing this as your presentation on your menti.com. So where we can
Right.
take the QR code.
Right. So yeah. So if everyone can either QR code or get your phones out, we're going to just kind of take a quick poll and kind of see where everyone is. I've been using Menti a little bit just because it's kind of neat. Highly, if you guys are using it, it's great. If you're not using it, especially for virtual, we're now going back to virtual because we're getting kicked out of our conference. Menti is, kind of getting there. So I'll leave it on a little bit longer. So just to make sure that everyone can kind of get to it. The QR code is actually pretty quick, or you could just go to menti.com and enter the 53588919. I'll leave it on for just a little longer.
Dave, a complete site, you think is better than poll everywhere? Just for my.
Yeah, I mean, I'm just learning. If anyone's a Menti god or goddess, would love to hear it. The problem is it doesn't embed as well. I think poll everywhere embeds into your but I think Menti, actually their trial stuff is pretty good, but then when you have to go to the pro edition, it really opens up. It gives you a lot more interactive. There's actually a team part as well, so it's actually pretty neat. So all right, for the sake of time, what I'll do is I'll kind of think. So when you think of fast, what's the first thing that comes to mind? So you should be able to kind of type in things that what fast actually means to you and kind of how this goes. Trauma, great. MVC, adult, accelerate care, fun, love it, free fluid, anasarca, right? So the thought is it just for trauma, right? It's, and the thought in a lot of the open source like journal feed and a lot of the filtered websites are really talking about, are we just overthinking EFAST? Are we trying to fit a square peg in a round hole? And in the meantime, really, I've had pretty heated discussions with my surgeons, useful in kids. I think the application of a FAST is useful. The question is it useful in trauma, intra-abdominal injury, right? So, and pretty fast, I like that. Ectopic, wonderful, easy. These are all great things, and, the idea is that it may not be just for trauma, right? I agree. Pericardial centesis is really something that is really I think really useful, and it's not just for abdominal fluid. We can talk about what else can we use ultrasound for in trauma, but this is great. Thanks, guys. All right. Do you routinely perform EFAS examinations on your trauma patients? Should have some music. Will Mac, maybe you can put on some music in the background. All right. Oh, so that's good. Okay. I know where our shop is, so, all right. So that's actually pretty encouraging that you guys, the 9 institutions or the 9 people that are replying that you perform EFAS and that's awesome. All right. So the biggest hurdle in performing FAST exams, what do you guys think? Training, excellent. Yeah, our shop and Matt and Will can kind of attest to it. It gets tough, because it is a really push pull or really more of a push with our other subspecialties. Surgery butts in. All right, training, surgery buy-in. I think instead of butt in, I think you probably meant buy-in, but maybe I'll take it differently. Space. Surgeon, space at the bed. Okay. Ultrasound machine not available. Surgeons. Wow. Okay. Buy-in from surgery and space, time and pressure. Too many people by bedside. Okay. Anyone using handhelds for trauma? That's another thing to get around the space at the bedside, just to kind of get in without getting into saving the images and all that other stuff. But by overwhelmingly your responses is time, space, and our dear pediatric surgical colleagues. So thanks for doing that. So successes, right? So where has FAST made a difference for you guys? So this is where I want to kind of open it up to the group, because I want to kind of see for you guys where are your successes? Like, how did you guys, in the people that of the 9 people that have done it, and this is where we can kind of open up the discussion. I don't think I have any more mentees. I think that was the last one. So so I'm going to stop sharing screen, and this is kind of where we can have a conversation and the discussion with the group, if everyone wants to kind of turn on their cameras and stuff. But the idea is that in your shops, what are you doing? How are you guys navigating surgeons? Are you not? Is it again a fight, a battle that's not worth it? I'd love to get everyone's opinion on this.
Did I hear that there's a PCARN study that is looking at FAST that is not the Holmes article? I seem to think that there's one that's getting off the ground, but I wanted to know if anybody knew what that was.
Definitely not aware. Maybe there's someone in the audience.
So I think the best study that I would love to do would be looking at the fasting and like as a predictor for OR management of intra-abdominal injury, because it's one thing to find that you have a splenic laceration or a hepatic laceration, but it's another thing to do anything about it other than have them sit in the hospital and watch and monitor vital signs. Henry, isn't that what you guys do at your institution? I'll never forget the day you presented and during one of our workshops, and the whole room stopped because you said that in your shop, if the FAST is negative, sometimes if their vitals are reassuring, that you may actually not do anything and watch them admit them and see what happens.
Yes, definitely surgery independent, but usually the head of the surgery department is he's very pro like reevaluation. He's also commonly admits suspicious right lower quadrant veins for observation and repeat serial abdominal exams. So he will be the one that is negative FAST, kid looks fine. He will admit him for obs. And then obviously if there's any change in the pain or anything, then they'll do a CT, which brings to the point where I think I found it useful, and I've seen a couple of wins, is because it's reproducible and repeatable, and we don't have to think about radiation. I had a couple of cases where the ER residents have reassessed the patient because they started having developing abdominal pain, and you go from a negative exam to a positive scan. and then that leads to either the CT or OR. That's where I seen it more likely. And then for me, I think it expedites care. I seen a couple of falls that were suspicious, and I put the probe, and then there's a huge fluid, and I just called the surgical team and then just tell them that, you know, it's pretty big, concern for the OR or CT. So.
Anyone else want to kind of tell us what you guys do in your own shops? Antonio?
Yeah, so I mean, I think we are supported in doing fast by our surgical colleagues. For the most part, we are getting cross-sectional imaging on patients that they're concerned about it, or they're going to admit even. We don't do what Henry's describing. Doesn't happen a lot here. I think our group tends to want to take a look on the way to the OR, even for hemodynamically unstable patients, for whatever that's worth. But I think for us in PEM is so different than if you're a surgeon or if you're a cardiologist or if you're a rheumatologist, because the denominator of the patients that we see is different than the denominator of patients that we ask them to help us manage. So, you know, I've had plenty of hemodynamically stable blunt abdominal trauma patients that we've upgraded to more modified trauma protocols. And I recall one from several years ago that the only reason the fast was done was because the parents were worried in a toddler who took a beanbag going down 10 flights of stairs. That's no longer a modified trauma for us. And the belly exam was pretty unexciting, and they just, in quotations, wanted to do something for the family. And it was a belly full of fluid in a 3-year-old who had high-grade splenic laceration. So I think for us, we just have to be careful about the disposition piece, because, working with other services aside, at the end of the day, we're the ones responsible of allowing patients and families to go home and, resume their normal activities or usual activities. And if it's a kid or, an athlete who plays sports and wants to get back on the field, my mindset is always going to be to take a look. And we teach the fast limitations, and it's not the holy grail of the trauma workup, but just for me, it's such a vital, important piece. I can't conceptualize taking care of patients with abdominal pain and abdominal trauma without that screening test. But and I'm putting a comment about some thoughts of the Holmes paper, but I don't want to hog the airwaves here.
Okay, thanks, Antonio. Anyone else want to kind of let us know what you're doing in your shop?
Dave, this is Matt. I had to transition to my car because my son is guilt tripping me for going to Scuff this weekend, so I have to go get some kid time in. Can you hear me?
Yeah, we can.
Yeah, so we've had a lot of fights both, and I'm involved on both the adult and ped side for our fast sort of stuff, education to surgery residents and workflow. The surgeons still get dinked, at least at our site, for not having a robust sort of oversight to the fast exam and their trauma performance, even though none of them actually care about it. And so we're in the process of transitioning to we have historically been surgery driven on our traumas, surgery driven on the fast, even though they get very minimal training, and our PEM fellows and EM residents get much more robust training. So we're now in the process of transitioning that out of surgery's ownership into our ownership, which will allow us to have better more consistent performers who have been trained and having, we save everything in a QPath, get QA'd, all that sort of thing. So I'm hoping that we will start seeing a better performance on that side. I feel like the lit that I've seen largely, like I always question who's actually doing and reviewing these. And I guess my other thought is similar to Erica's, which is I would love to see something where it's true outcomes that make that involve intervention, sort of similar to like the PCAR head injury study, where, you know, they're not saying that you don't have a head bleed. They say you have a head bleed, it doesn't really matter, or the ones that matter. I've gotten into it from a couple of outside docs who like head scan kids that were low criteria and found something, and then, you know, instead of like, why'd you scan them? Like, we found something. I'm like, yeah, but you found something that will make a difference. And I wonder if a lot of our fast data is similar. You know, even like the grade 4 splenic lax, it does nothing. Like, so you found it, so what?
Matt, are you saying you guys are actually QAing the surgical images that they're doing? Like you're helping training?
So we do training for the surgery residents a couple times a year. And I was part of a QI project to get them to start saving and being able to run QA. And so we took our QPath like interpretation template and basically forced it into their notes. Because at least for my trauma time as a fellow, you know, the fast was done oftentimes while walking to the CT scanner, sometimes with the machine not on, and somebody hollering fast negative without any sort of like qualification to individual windows or anybody with any training actually overseeing it. And so surgery had gotten knocked on one of their site reviews for having basically no real QA or oversight to this. So that was their solution. And the downside was, even after doing all that, the surgery resident never saved images. So that sort of died, which is why we're now transitioning to having it be EM, and then here just soon to be PIM, like taking ownership of the fast and doing it, performing and recording and documenting.
That's a lot of work, Matt. All right. At least you're at least part of the process, I would imagine. But it seems like that would be a lot of work to undertake. But it sounds good. Anyone else want to kind of comment on their shop and how they do fast, or how it's incorporated, and successes and failures, maybe?
My sense is that at our shop, it's really wanted for the really unstable patients, and they really care, but they don't have a ton of patients for the learning process. And so we get a lot of pushback, like when surgery comes to the bedside and they ask, why are you scanning this stable trauma patient? I don't think that they have a lot of understanding of the training process or the triage process required, right? So if you get a multi-trauma, one of them's got free fluid in the belly and is stable, one of them doesn't and is stable, you're going to triage them differently. I don't think our colleagues have that sort of ER mentality that is required, you know, to run an ED efficiently.
We hear that too on our side. It's kind of annoying, but we do hear that on our side. I gotta imagine other people as well. So I really thanks for everyone's input. I truly apologize for the technical glitches. Never happened, and hopefully won't happen again, but I truly accept my apologies. Henry, thanks for kind of having me on. I have to thank Will Mack and Matt Kasoulis as part of our kind of ultrasound team. There's no way we would be as successful as we are without their help. So thank you guys, and just want to put a shout out to Erica and your team. Our hearts, our prayers, and everything go out to you and your family, your work family over there. Okay, we're with you.
Thank you.
I second that, Dave. So I would really truly sorry to hear Eric about it. So our hugs and prayers over there. Dave, thank you again for presenting. Thank you. You know, you gave me a new approach to the study that we gave, so I'm actually going to try it. I was actually texting Lori about because we never really thought about using the curvilinear probe in that
All
way.
due respect. All due respect. Tell her all due respect.
No, she was like sad because she has a IT meeting right now that she's doing, and so I told her I got to try it out. So I thank you, and then this I mean, this is why I like this platform, because you know, you get to learn. So thank you for that, Dave, and thank you for presenting.
No problem. And if there's a chance in the future, maybe I'll be able to give this again, hopefully in higher broadband, but we'll see. But thanks, Henry, as always. And thanks everyone for joining. Happy holidays. And Erica, we love you, sweetie. All right.
Thank you. Bye, everybody.